And as we are already running a bit late by 5 minutes, I'll just invite the first speaker. And I have with me, I myself am Dr. URMIL CHAWLA, Professor in Regional Institute of Ophthalmology, Rohtak, PGI. And I have with me Dr. S. Ambika from Shankara Netralaya. And I would like to invite the first speaker, Dr. Sumit Lahane is there. So he's going to speak on evaluation of the lacrimal system.
Good morning, everyone. Welcome all of you to this EyeShala in the DreamCon. So, I thank Dr. Santosh Onava sir and the AIOS Scientific Committee, Organizing Committee for giving us opportunity to be here. So what I will be discussing is the evaluation of the lacrimal apparatus. So this is how the 30 to 40% of the patients come in your OPD complaining of aankh se pani aa raha, it's watering. And how do you approach this epiphora cases? So epiphora is nothing but it's implying that there is a overflowing of the tears, and you know then when there is a overflowing, either there is a hypersecretions or there is a drainage that is blocked. So this is something that is not given anywhere. It's a grading of epiphora. It's basically no epiphora is grade 0. Grade 1 is when you go into a windy storm kind of a weather, then there is epiphora. Otherwise, grade 2 is outside epiphora without irrespective of the weather, and the third is there is outdoor, indoor, irrespective of everything, there is epiphora. So now when you want to enumerate the causes, theoretically there are a lot of causes, hypersecretions and the defective drainage. So hypersecretion has a lot of causes from neurogenic, abnormal lid globe position, ocular surface disorders, facial palsy, and lot of it to remember and write. Now defective drainage, again there is everything blocked from the punctum to the nasal conditions, and again there are a lot of causes, boring, difficult to remember. So when you have so many causes and you don't know how to go ahead with, theoretically you may be able to just read again and again and write it, but it would be best when in your OPD you know how to approach a patient. So when the steps are difficult, the stepwise approach is always better. So taking into consideration all of you know the anatomy of the lacrimal apparatus, two things that we keep on forgetting in this is wall of Hassner and the wall of Rosenmuller. So you try to remember any which way that the upper is R and lower is H, RH, any which way, whatever fits in your brain, try to remember this way. So Rosenmuller, for your information, was basically a anatomy professor from Germany who discovered wall of Rosenmuller almost 200 years back, and wall of Hassner was ophthalmologist. So in the step 1 of your practical approach, the first most important thing that you should do is do a clinical examination. Try to see on the slit lamp, because many of the times, especially in the elderly and very younger population, what you miss is a punctal occlusion stenosis or the absence of the punctum. And this is a very much easily treatable condition. If there is a punctal absence, then of course you need a tube. But if there is a occlusion or the stenosis, that can be very well treated. So this is a small simple surgery which everyone should learn even during their residency. So you dilate the punctum, you make 2 snips, one lateral and one medial, and you just join, and that's it. This is your punctoplasty. I will just repeat the video for you again. So you dilate the punctum, you do put a topical anesthetic, do give a 0.5 ml of lignocaine, 2 snips and 3 snips joining them. So it's very simple and easily doable procedure which solves your issue. Now step 2, when there could be some other cause other than punctal stenosis, when slit lamp examination is normal. So there could be block anywhere. It could be upper lower canaliculus, common canaliculus, or NLD. Then what test comes to our help is a sac syringing test. This is one of the first tests maybe in the OPD after retinoscopy that all of us as a PGs do. But the interpretation we never learn. So how do you interpret this? So very first important that we should try and follow the protocols. When you are doing this sac syringing, ideally we should use a glass syringe. Most of us don't have in our medical colleges, but the glass syringe will be ideal with the good nice cannula which is made specifically for the probing, for the syringing, sorry. So this is a patent syringing. When you put it and the patient sees that I can get the water in the throat and that's it, your canalicular lacrimal apparatus is clear. Now, when you get a regurgitation from the same punctum, what do? Either it comes from the lower or upper. In this example, I'm showing you the lower canalicular block, and you get the reflex from the same punctum. You also have a difficulty in passing your cannula. So then you repeat the test from the other canaliculus and see is it patent or not. So if it is patent, then you know the other canaliculus is blocked and partially it is the other one is open. So you know this is a canalicular block, either upper or lower. Then, when you're doing a sac syringing, there is a regurgitation. Now, you need to be little more experienced to understand that regurg is coming very fast or it is taking some time. It will be from both the puncta as such. So, if it is very fast, then you know it's common canalicular obstruction. It is taking some time, then you know. But again, in the early phases, it is difficult to understand, and when we do it forcefully, again, we cannot interpret that how fast is the reflex coming. So, what do you do in such cases? Then there is a step 3. Then you are not able to differentiate between a common canalicular and the NLD block. Then you do something called as a probing. Okay. Then this is a Bowman's probe. There are various sizes available. So you dilate the punctum and pass the probe. So when you feel a soft stop anywhere between the canaliculus, 7 to 8 millimeter, that's what the length of the canaliculus is, and then you know it's a soft stop and there could be a common canalicular block. In common canalicular block, again you will notice that the medial canthus of the patient is getting shifted towards the medial side when you're doing it very forcefully and patient is experiencing pain. So you know this is a soft stop, and now what are you dealing with is basically the regurg is coming from the early block, which is a common canaliculus. Hard stop is something that you're able to pass the probe very easily, but you're hitting the bone and you're not able to pass it further. And that time you know the canaliculus is basically clear, and what are you dealing with the nasolacrimal duct. So step 1, step 2, step 3, all simple. You do it in a phased manner and you understand. Now what happens, the problem, here the treatment is either canalicular DCR or DCR depending on the block. The problem happens when there is a partial block with the clear regurg. When patient is complaining that there is issue and you get a hard stop, and then there are two residents doing it. One very thin, lean, and he says that yeah, there is a regurgitation happening. Another fat fellow comes and uses all his force and all the anger on the professor is taken while doing the sac syringing, and suddenly he finds it is patent. Now there are two different findings in the same patient, and there is a fight that it's patent or it is regurgitation. So now when you are stuck at this phase, now the help comes with the step 4. So this is the dye test that we do. There is a drop of a fluorescein that we put in your conjunctival cul-de-sac, and you put a bud which is dipped in a lignocaine or proparacaine, and then you keep it in the nose. Then if you get it all stained, then that's a positive thing. And the positive Jones 1 test is basically the system is patent and the watering is because there is a hypersecretions. Now if you get negative test that your bud is not getting stained, and this is a more of a physiological step, you are not using any extra force to put the stain ahead like you are doing in the sac syringing, then you know that the blockage is either upper lacrimal system or the lower lacrimal system. So either there is a pump failure or there is a partial obstruction. Now, once the test comes negative, we need to do another test. So that's called as a Jones dye test 2. In this, we purposely do a sac syringing and try to force the whatever fluid or the whatever fluorescent dye which is already there in the lacrimal sac or in the conjunctiva. So suppose it has already entered the lacrimal sac because the pump is working well, and you put it very forcibly and then you get it, then you know the upper lacrimal system functional and partial block is in the lower NLD. And the second time negative test basically tells you the upper drainage system is faulty. That is a pump failure. Basically your orbicularis and the lacrimal sac are not functioning well and there is a problem. So this is a Jones dye test 2 negative, and you have a pump failure upper side. So in pump failure, again doing any surgery is futile and that may not work in the patient, but instead you get a positive test in the second attempt, you know the DCR will be a good treatment for this. So again, just to revise, step 1 is clinical examination because you want to see that is there any problem with the punctum itself or any other small things which you will come to. Step 2 is you do a sac syringing and try and interpret. You will get stuck only when there is either a common canaliculus block or there is a NLDO block. Then you do a step 3, which is probing. So you either get a soft stop and hard stop, then you are able to differentiate. And fourth, you have to do only when there is a problem, that there is a partial regurgitation and partial patent, and you don't know what is the problem happening and should you operate or you should not. This test will help you to do that. There's one more test, dye disappearance. This is more useful in the children when you know they are not let you examine. You can just put a fluorescent drop and they're crying in your OPD. You can tell them to come back after 5 minutes, not to wipe eyes, tell their mothers. And then you see after 3 to 5 minutes also the dye is still there, then you know that there is some problem with the lacrimal system. So this is a dye disappearance. So many times parents are not able to tell you that which eye is watering. There are few causes which all of us should not forget, especially in children. One is epiblapharon. These are again some causes of the hypersecretions and not of the lacrimal apparatus problem. Another is trichiasis. Another is congenital glaucoma. And this is something that you again miss. That patient is completely normal. The punctum is still open, and you are doing sac syringing. It is patent, but patient has a positive dye disappearances and not able to. You're not able to find the problem. This you will find in a young adolescent person. So here some findings I would like to show you. You see this hair between two eyebrows. Anyone, what is it called as? Raise your hand. Yeah, synphresis. So basically this one feature. Another one, I have put an arrow where you see that the angle, here you see the angle of the medial canthus, and especially it's very much acute angle. Thirdly, when you see on the slit lamp, you will find the eyelashes which are there. The pars ciliaris, basically it gets over at the punctum, but in this case you will see that those eyelashes are covering the puncta as well. So all these features basically constitute nothing but a Centurion syndrome, where you find everything normal, but again there is a patient having watering. That is because of the configuration of the all lacrimal apparatus, and this is again a very easily treatable situation. Only thing is you need to diagnose it correctly and not keep on giving patient eye drops which will increase his watering instead of relieving him. So these are the conditions which you should not miss on your clinical examinations. To summarize, epiphora should be differentiated from the lacrimation. Stepwise approach is must, and well done syringing and probing, and more than that, well interpretation of the same is very important. And DCR and intubations are important surgical procedure which you must learn in your residency itself. I thank you all for patient listening. Thank you, ma'am.
Thank you, Dr. Sumit. That was a wonderful talk. Now I would invite my co-chair, Dr. URMIL CHAWLA, Senior Professor, Oculoplasty, PGI Rohtak, to give the next talk, Evaluation of a Patient with Ptosis. I request all the speakers to kindly stick to the time so that we can have some amount of fruitful discussion at the end of the session.
Okay. So after the lacrimal system, let's talk a little about the lid. And ptosis is one of the cases which I think is given almost every time in the exams, either as a short case or as a long case sometimes. So, and if you are well aware of the evaluation part, which I'm going to cover, I'm not going to go to the surgical part as it is going to be discussed post-lunch. So the evaluation part is more where the examiner stresses, because he knows as a MS candidate, you must have not done surgeries on ptosis, but the evaluation has to be a must. And if you want a result as good as shown in the picture of a ptosis surgery, you have to be very thorough with the evaluation part. So ptosis, as you all know, is nothing but the drooping of the upper eyelid. And to evaluate the ptosis, we begin first of all with the history. Onset, whether it is congenital or acquired, makes a difference because the management as well as the evaluation points are different, which I'll discuss. Laterality, again, whether it is unilateral or bilateral, the measurements will vary. The way you have to measure, again, we'll be discussing. Progression, if it is increasing, it goes in favor of CPEO. If it, and generally congenital ones may be constant, and the acquired ones, if they are there, they might show a decreasing pattern also. Variation, diurnal changes goes in favor of myasthenia. So as soon as you get a history of diurnal variation, immediately it should strike your mind. Any allergic reactions or drugs which are causing edema, which can lead to a pseudotosis, should be asked and kept in mind. Any medical history and family history for certain conditions, again myasthenia, CPO, etc., which may be helpful. Any association in history with the jaw movement, as you know, there's a phenomena, Marcus Gunn we'll be discussing, that goes in favor. The patient will give you history that whenever the child is moving or chewing, the eye is flickering. Abnormal ocular movements, as you know, double elevator palsy can be associated with ptosis, strabismus in other forms can be associated, and that alters the management again. So that has to be asked. Abnormal head posture, especially in bilateral ptosis, you'll find a chin lift, you can find a face turn also, so that history is very important. Trauma or previous surgery may be the cause of acquired ptosis. Use of steroid drops. Post-cataract surgery ptosis, one of the most common causes is use of steroid drops. You can be asked in exam what are the other causes of post-cataract surgery ptosis. It can be trauma by the superior rectus fossa, eponeurotic trauma. All these can be the causes of post-cataract surgery ptosis. Any bleeding tendency, so that you are prepared on the surgery table. Dysphagia, dysphonia, dysarthria again goes in favor of myasthenia. So all these aspects you have to be very careful while taking your history. The psychological aspect, very important, because it will help you in deciding the timing of your surgery. Sometimes the child may be having a mild or moderate ptosis, not causing amblyopia, but the peer pressure is so much that he's developing depression or whatever the reason. So you should consider that also. And some are very casual, so they go on for a longer period. So psychological impact is one factor. And again, the photographic documentation. Ask the parents to get the photographs. If they're adult, they can show you their photographs. Nowadays, we have so good access to photographs. You should have a documentation pre-op so that you are able to explain later on. Never overlook the basics. Visual acuity, very important, because you know ptosis can lead to amblyopia due to two causes. Either it is severe ptosis leading to disuse atrophy, the eye is not being used, or it can lead to meridional amblyopia also due to the weight of the lid. So you have to be very conscious about the visual acuity. It should not be that you have operated and the parents say that the surgery has led to the diminution of vision. So very important to have a pre-op assessment of the vision. A cycloplegic refraction must, IOP, fundus, and you come to the measurements of ptosis. Yes, as we say, the eye sees what the mind knows. Unless or until you know that there is a term called pseudotosis, it will not strike your mind. So there are a number of causes where pseudotosis, like an enophthalmic socket in a thysic eye, in an enophthalmos with flow fracture, and very commonly lid retraction in early thyroid. For first year PG generally comes running, ma'am iski left eye mein ptosis hai. But when you see, it is the other eye that is having lid retraction, and that is not the ptotic eye. Even the parents will come and say ki iski yahan choti lag rahi hai. They will miss the point that the other eye has palpebral fissure is enlarged. So lid retraction is one of the very common causes of pseudotosis. So keep in mind, first of all, whether when you are starting assessments of ptosis, whether it is a true ptosis or a pseudotosis. Once pseudotosis there, it is outrightly, the case is out. Then you go ahead with the true ptosis measurement. Now, when you appear for your exam, you have to have these points in mind for the ptosis examination. Head posture, as I told you, as soon as the child enters your room, you can observe the head posture, history also, and your observation will help you. As I told you, bilateral ptosis will have chin elevation, or a unilateral ptosis can have a face turn also. Frontalis action, again, very important, because if patient is having severe ptosis, but a good frontalis action, it goes in favor that a sling surgery will be successful. So you can ask the patient to arch the eyebrows, and you can observe normal frontalis action is around more than 10 mm. So observation of the frontalis action is very important. Then eyebrow, there can be brow ptosis, so you have to be careful about that. Very important point which gives a cosmetic appearance to the eye is the lid crease or the lid fold. I'll come to that in detail. So presence of a good lid crease goes in favor of mild or moderate ptosis, or an absent lid crease may go in favor of a severe ptosis, and a high lid crease goes in favor of acquired ptosis. We'll discuss this one by one. Lid margin for any entropion, trichiasis, or any other marginal abnormalities. Then the most important points, two most very important measurements which help you in measuring the amount of ptosis is the palpebral fissure height and MRD1. So palpebral fissure height, horizontal as well as vertical. Practically we go for the vertical one, but in some cases like in blepharophimosis, the horizontal measurement is very important. Vertically also take care that you check in the primary gaze, up gaze and the down gaze, though the measurements practically we would use for the primary gaze. Coming to the MRD1, the distance from the upper lid center to the corneal light reflex, very important, we'll discuss. MRD2 is the distance from the corneal light reflex to the lower lid, and normally the PFH should be equal to MRD1 plus MRD2. Then, so amount of doses can be measured by two methods. I'll tell you which one is better, MRD1 or the PFH. Then you come to the 3L, the levator function, another very important factor, because that is going to be the decisive factor of your surgical option. Lid lag, a very common feature in congenital ptosis but absent in acquired ptosis. Lid lag is that when you look down, the lid does not follow the globe because it is dystrophic LPS is there in congenital ptosis. Lag of thalamus, because your surgery is going to lead to some amount of lag of thalamus. So any pre-existing lag of thalamus should definitely be noted, because that's going to increase and you should be aware of that. Bell's phenomena, Marcus gun jaw winking, and ellipse. The three phenomena, very important, because your management is different, and if it's a poor Bell's phenomena, it's a poor prognostic sign, you have to undercorrect. Marcus gun, altogether surgery is different, we'll discuss. And ellipse is done in very small children. Just to have a gross idea of the LPS action, you just invert the lid and ask the child to look in upgaze. The reverting back of the lid to normal immediately will tell you that it is grossly functioning normally. Extraocular movement to rule out strabismus. Corneal sensation, again, both Schirmer's and corneal sensation for any neurological deficit on cornea, or Schirmer's test for dry eye because they are bad prognostic features. Pupil, again, whether it is mydriatic, it could be a third nerve palsy, myotic in Horner syndrome. So you have to have a look at the pupil, and of course the vision. So as I told you, you can again look at this: head posture, frontalis, eyebrow, lid crease, lid margin, PFH, MRD1, the 3L, then the three phenomena, three ancillary signs, and the pupil and the vision. Now, if you can remember this mnemonic, destiny, the few important things: the drooping of lid, E for excursion of the lid, the LPS function, S for the superior rectus function, tear film evaluation, ellipse test, Bell's phenomena and corneal sensation cover the neurological, and the Marcus gun by yawning. And again, there's three bad prognostic indicators known by the mnemonic BAD, where the Bell's is poor, cornea is anesthetic, and the dry eye is present. So these are bad prognostic. Either you undercorrect or you may have to avoid surgery altogether. Now coming to the actual measurements, frontalis, as I told you, you have to see the arching of the eyebrow. That gives you a clue that severe ptosis, you can go ahead with sling surgery. Upper eyelid crease, what is the difference between lid fold and lid crease? Lid fold is the one that we see in primary gaze, the fold that comes on the upper eyelid. And lid crease is measured when we ask the patient to look in the down gaze. So in normal values, you should be knowing female 5 to 8 and men 4 to 6. Absent lid crease, or as I told you, is a marker of a poor levator function, commonly seen in congenital ptosis. And a high lid crease is a marker of levator disinsertion, a very common cause of acquired ptosis. Then PFH, as I told you, it should be MRD1 plus MRD2, distance between the upper lid and the lower lid. Again, you have to know males 9 to 10, women 9 to 12. Upper lid should cover 2 millimeter below the superior limbus, and lower lid just touching the inferior limbus. And accordingly, if it is a unilateral ptosis case, the difference between the PFH of two eyes will give you the amount of ptosis. But if it's a bilateral case, measuring the amount of cornea covered by the upper lid, and then we subtract 2 millimeters, that will give you the amount of ptosis, and we'll grade it mild, moderate, severe, depending upon whether it is a 2 millimeter, 3 millimeter, or 4 millimeter droop. Now coming to the very important aspect, MRD1, which as I told you is the distance between the upper lid margin and the corneal light reflex, normally 4 to 4.5. If the lid margin is above the light reflex, it will be a positive value. But if the lid is covering the light reflex, I'll show you how we check the MRD1. You have to lift it and see, and that will be labeled as a minus MRD1. And it is a sign of severe ptosis, as you can see in the pic. On there's a negative one because the reflex is not visible, and in the other you can see the reflex, so that gives you a positive. And then MRD2 has its own significance because it is the distance between lower lid margin and the corneal light reflex. Sometimes the lower lid may show retraction, and that is where the MRD2 role comes into play. I'll show you. Now, these are theoretical points. Your examiner may ask if he's an oculoplasty surgeon. MRD3 and MLD, these are generally not practically used, but MRD3 is the distance between center of upper lid margin and the corneal light reflex in extreme upgaze. The difference between the two eyes multiplied by 3 generally was used to calculate the amount of LPS that used to be resected. Similarly, MLD was the distance between upper lid to the 6 o'clock limbus, and the difference between this and two eyes again multiplied by 3. This is normally not not being followed, at least I don't follow. Now coming to the measurement doses, as I told you, there are two methods, the PFH or the palpebral fissure height and the MRD one. See, in this example, suppose we take the primary gaze, right eye is having 10 mm doses, 10 mm palpebral fissure height, and left eye is having 7. So the amount of doses comes to be 3 mm. When I do the MRD1 test, right eye is having value of 5 and left eye is having 1. Now when I see the difference of the two, it comes to 4 mm doses. So, and as I told you, MRD1 plus MRD2 should be equal to PFH, that is okay. But now what to do? One is saying 4 and one is saying 3. So why is this reason? Your measurements are normal. You have made no error in your measurements. So what you see here is, just see that the lower lid is not touching the inferior limbus. There is lid retraction of the lid retraction on the lower side. So that is giving a more MRD2 has increased. In such cases, MRD1 will be the measurement that you will take. So MRD1 is definitely a more superior method for measuring the amount of doses than the PFH method. Otherwise, generally both will come same, but whenever there is such kind of situation, you will opt for the MRD1. Now coming to the levator function, as I told you, it is a very important test. Patient is instructed to look down, block the frontalis action with the thumb, ask the patient to look extreme down gaze to up gaze, and you grade 15 is normal, more than 8 is good, 5 to 7 fair, and less than 4 is poor. I'll just show you the method of LPS. See, in this case, if you elevate the eyebrow, this is a wrong method of taking the LPS action. Here you are pushing the eyebrow down. So again, this is again the wrong method of taking the LPS action. See, this is the right method. Just keep your thumb over the brow and give a posterior pressure. You don't have to take the eyebrow above or down. Be careful, and then you take it from extreme up gaze to the down gaze. Now coming to lagophthalmos, as you said, as I told you, lagos is the Greek word for hair, an animal which sleeps with its eyes open. And you must have seen in some cases it is physiological also, the inadequate closure, and otherwise it is facial nerve palsy. As I told you, post-op we can have lagophthalmos, so it is an important parameter which you should be careful about. Lid lag is the incomplete lowering of the ptotic lid in down gaze, more common in the congenital ptosis. Bell's phenomena, it is a protective reflex. As you know, efferent is by facial nerve and the efferent by the oculomotor nerve. We grade it. Normal is when the cornea rolls up and out. Inverse is when it rolls up and in. Reverse when it down and in. And perverse is when bizarre direction it is moving. And we grade it good, fair and poor according to the amount of cornea that remains visible. And the significance of Bell's phenomena, as I told you previously, if it's a poor Bell's, it is definitely a bad prognostic sign. So you do either an because we cannot correct the ptosis and let the patient go into exposure keratitis and ruin the cornea. That will be more of a problem for him than the ptosis that was present before. So you have to be very careful in that. Ellipse test applicable in children, just a patient looks in down gaze, evert the upper lid, again looks in up gaze and immediately reverts back, so it shows that levator action is good. Again, I'll just show you a comprehensive evaluation of whenever you have a ptosis patient coming to your room. Immediately as the patient comes in, check for the lid gaze. So you ask the patient to look down, you see that in the right eye, the palpebral aperture height increases. So this is the lid gaze. Now in the primary position, you just need a simple ruler. We are seeing the lid fold. This fold that is coming in primary gaze, measure the lid fold. Ask the patient to look down gaze and see the lid crease. If the lid crease is very faint, you can assess it in the other eye also, and measurement you can take. Now you take the palpebral fissure height from up to down. Then you come to the MRD1. Now in this you see that pupillary reflex is not visible. So what you need to do is elevate the lid and see for the reflex, and so the value will come to be minus 0.5 or 1, whatever it is. Then you see the MRD2 also. Coming to the LPS action. This is the LPS action from extreme up gaze to down gaze. And then we come to the this is your Bell's phenomena. You ask the patient to close eye. Both ways you can see, either in an open eye or with the closed eye. Bell's phenomena should be checked. Corneal sensation should be checked in both eyes. Schirmer's should be checked both eyes. And finally, after Schirmer's, you check the Marcus gun phenomena. So again, you check the Marcus gun phenomena. So now coming to congenital ptosis, as I told you, main signs were lid lag, lid crease faint or absent, LPS action decreased. Complicated congenital ptosis can be Marcus gun, blepharophimosis, and superior rectus weakness. Marcus gun, 5% of all congenital ptosis can have this. Fifth nerve and third nerve, you know it's a misdirection. And as the child opens the mouth or chewing movement, the ptosis will decrease. So there are two major groups. The external pterygoid levator synkinesis is the more common entity. In this, when the jaw is thrust to the opposite side, the Marcus gun phenomena occurs, or when the mouth is widely open, while in the internal pterygoid, lid elevates on teeth clenching. Then inverse Marcus gun is there, where instead of increase, the ptosis is caused by this. It is also called as the marine amat syndrome. However, it is debatable. Some people say the marine amat is because of the orbicularis muscle, due to the misconnection between fifth and seventh nerve, while inverse Marcus gun is due to fifth and third nerve. So it's a debatable, but in this, ptosis increases on opening the mouth. You have to grade the Marcus gun according to the excursion of the lid that happens less than 2 to 5 or more than 5. And accordingly, if it is a mild and patient is more concerned with the ptosis and not with the Marcus gun, you will treat him as a routine ptosis patient. But if it is the Marcus gun that is troubling him, then you have to, the surgery is altogether different. You don't have to go for a resection. You have to go for a excision of LPS along with a sling surgery. The blepharophimosis, it is a tetrad of blepharophimosis, that is the horizontal narrowing of the palpebral fissure. Ptosis, generally severe bilateral symmetric. Telecanthus is the increase in the intracanthal distance, and a skin fold that is present is epicanthus inversus. And associated symptom signs others may be there, and it is labeled type 1 if ovarian failure is there, type 2 if it is absent. So in extra examination, besides the routine ptosis examination, in this would be the horizontal palpebral fissure, the intercanthal distance, and the interpupillary. Normally, if our interpupillary distance is 60, the intercanthal is less than 30, so that you have a more than 2 ratio of IPD upon ICD. But in this telecanthus, your this ICD will be more, around 35, 36, and your interpupillary is still the same. So that will give you a less than 2 value, and then you know that it has. This is an operated case. You do it in 2 steps. First, the CU plasty and the lateral cantholysis to increase the horizontal, and after 3 months you can do the sling bilateral, or you can do it in one sitting also. Now coming to the superior rectus weakness, rule of the thumb is that if there is a vertical strabismus associated with ptosis, you have to correct the vertical strabismus first, followed by the ptosis surgery, although you will many times see that the patient is more concerned with the ptosis, because that is visible. He does not know that much worried about his elevation deficit, but you know that you have to bring the eye in a normal position, then only you can have a good ptosis result. You cannot go ahead with this. Coming to the acquired ptosis, you have aponeurotic, in which comes the involutional and the traumatic, myogenic, neurogenic, and the mechanical. And acquired, you have few investigations extra. We have to be careful. Defects of levator aponeurosis occur in aponeurotic. Involutional is the most common. It can be post-op, blepharochalasis, habitual rubbing in patients of allergic conjunctivitis. As you see in this patient was having severe allergic conjunctivitis, and due to continuous itching, he has developed the levator dehiscence, and he has developed bilateral ptosis, and you see there is no lid lag, rather there is a lid droop in both eyes. So coming to the typical features are differentiating from congenital. There's a lid drop on down gaze. Levator function in congenital is decreased, but in this generally it is the good levator function. High skin crease because the levator has dehiscence has occurred and it goes up. So there's a high lid crease, and thinning of eyelid skin because aponeurosis becomes absent to the extent that you can see the underneath iris beneath it. So the difference, if you can be asked in your exam, the 3 differences between congenital and acquired ptosis. In congenital, in down gaze, lid lag will be present, while eyelid drop is present in acquired ptosis. Upper eyelid crease is poorly formed in congenital, but it may be higher than normal or absent in acquired. Levator function is reduced, while it is near normal in acquired. Coming to the myogenic, we'll cover the important ones.
Can you summarize, Dr.
Myasthenia, it is generally, ptosis is asymmetric and maybe unilateral. Coggin slit twitch sign is a very important sign. The patient is asked to look down for a short period, and when it looks up, there's a sudden twitching motion. Then diurnal variation, the ice pack test, very important, you can do in the OPD itself. You will see that after applying ice for 2 minutes, the ptosis improves. The hydrophonium test, it is more of a diagnostic than therapeutic. IV drug is given, while in neostigmine, it is an IM drug. So it also shows, again, this is a seesaw ptosis. Again, it is seen because asymmetry is there in myasthenia. This is because of the Herring's law. You raise the more ptotic lid, the other lid will fall because equal innervation is going. But when you raise this lid, that innervation decreases and the other eye falls immediately. So this is the curtain sign. CPO, again, early bilateral, no diplopia is there, progressive kind of thing. Then myotonic dystrophy can be there. Third nerve palsy, ptosis plus restriction of elevation, depression and adduction is there. And midriatic pupil is the clue for you. Horner syndrome, classical triad of mild ptosis, meiosis and anhydrosis. Along with it, you can remember this mnemonic, ample or sample, and you can see the findings of Horner syndrome. Very important in very mild ptosis or in Horner syndrome to do a phenylephrine test. If it shows improvement, you are sure that Muller's muscle is normal and you can go for a conjunctivo-Mullerectomy. Mechanical ptosis due to eyelid tumors, orbital lesions or cicatrizing conjunctival disorders or lid edema. Traumatic can be neurogenic. It's a Pandora's box. According to the etiology, you have to go for the management. Finally, the take-home message is that a thorough assessment is a crucial key point, and levator function is the deciding factor for the choice of surgery. Customized surgical solution is there, and never raise the hopes or the expectations of the patient too high before your surgery. Keep them low. You can give them a very good result and make them happy, but once you raise the expectations too high, it is very difficult to answer them. Thank you. Sorry for taking a little time, but the topic is so huge, and these are the patients of ptosis operated. So thank you so much.
Thank you, Dr. URMIL. I do agree that it's quite extensive to cover within 15 minutes. Now we move on to the next speaker. Dr. Desai is going to give an overview on logical evaluation of a patient with proptosis.
नहीं साउंड नहीं है किधर आ रहा है हाँ थैंक यू डॉक्टर अंबिका एंड डॉक्टर उर्मिल that was really extensive and it was a revision for me also. I'd like to thank the AIC for inviting me here and Dr. Santosh. I like this podium. Can be seen and not only heard. So everybody has a mobile phone, right? And everybody has pens and papers, just put them away because you're never going to read the pictures you take. I assure you that. Okay? So listen, we're going to make it interactive. We're just keeping pictures. There's not too much theory because honestly, there's a YouTube video by the who's who of oculoplasty, which is not me. I have no YouTube videos, but you have really good stuff. So let's just take and see a few pictures. Someone's taking a photo of me before. Oh, okay. It's my resident. Tell me, I'll smile before, huh? They will, but I'm just saying, just let's keep it interactive and fun. And there are a lot of patient full-face photos, so genuinely requesting, just it's going to be enjoyable, okay? So let's not get too stressed about it. So the first question we ask is there proptosis? So proptosis, as we know, is defined of a difference between more than 2 millimeters. Then what is exophthalmos? Can we use it for a case of proptosis? So in an exam, if you say this patient comes with has exophthalmos, will you be picked? Maybe, because exophthalmos specifically was described by Henderson for thyroid eye disease. So try not to use it for that. So the first question then is, if there is proptosis, or is there not proptosis? So is it pseudoproptosis? That's the first thing you ask when you get a case of proptosis. So let's take both these patients. The top lady has what she thinks this looks eye is prominent, proptosis, and then he thinks this eye is prominent. But if you see actually in this, the eye which looks prominent, that means the ipsilateral or the same side eye has a lid retraction. And what do you think here? Why does this eye look prominent? Yeah, it's ptotic. There's brow ptosis. It's a giveaway. It's very simple. So ipsilateral and contralateral eyelid signs. Then what about these two? One has bilateral and one has, this eye looks prominent. There's a little sign here, some ecchymosis. Yeah, correct. It's an enophthalmos, and this is actually myopia, but was been kept constantly told he has thyroid eye disease, but he didn't. He was a known myope. So basically, eyelid signs, globe positioning, and lastly, this girl here, which is facial asymmetry, very well seen, along with a lid retraction. You can see this entire side is hypertrophic compared to this side. So facial asymmetry. So first question is, proptosis is there. It's not pseudoproptosis. Second is it unilateral or bilateral? Yeah. So this is just a common laundry list kind of thing, just to remember. And at the time of the exam, you never remember this. You're in a state of panic, but it's good to know these broader things when you're answering. and then it's further divided into adult and pediatric. These are some of the most common causes. They're all there in your book. You don't need to take a picture because all of these are given in most of the books you read. This is according to age, so you can either divide it according to unilateral, which is most common, and bilateral, or according to age. And this is a very nice article which is given, which is easy to access on PubMed, and it's free, and it just talks about etiology of proptosis. So we've answered 2 questions. Let's get on to the third. So we know there's a proptosis. We say it's unilateral, okay? And then we want to know direction of displacement. So most of the times I just tell the residents that you have to know your anatomy. Whatever is there in that quadrant, it's going to push it to the opposite quadrant, and that's all you really need to know. So this first patient has a unilateral proptosis on the right side. Is it going anywhere? Not really, right? So axial. So axial proptosis, fine. Then this lady, very obvious, is getting an inferior displacement. Inferiorly, superior lesions is, what do you have on top? You have your frontal sinus, you have your lacrimal gland, you have muscles, your nerve. So muscles, nerves, fat, anything can come from those. But primarily, if you just rule out certain main structures, frontal sinus, mucosa, lacrimal gland. So these are some of, this is just a kind of a breakup of the, lesions that can occur. Blow-in fractures. And then this is a little subtle. If you see, there's a unilateral, what we call a telecanthus. So it's pushed laterally. So if you have a dacryocystitis, would you get this? Acute dacryocystitis? Not so much a lateral displacement. It would be more a superiorly, because your lacrimal gland is below your medial canthal tendon. So anything that actually causes a telecanthus is actually coming from the ethmoids. So ethmoid, sinus mucosal, tumors. So this is kind of the displacement. So we've answered question number 3. So now we say is the duration. And this sequence that I'm going in is something that Shields has described, but it's something that stayed with me through my UG and fellowship, and I really like it. So duration is catastrophic, which occurs within minutes and hours, acute, subacute, and chronic. And then, of course, the clinical course of the disease. Before we go to all that, you need to know how to measure it. It's good if you can have a Herter's exophthalmometry, and you can do it. Most of you, will have people teaching you. This is something that you should know, that is displacement. Displacement does not require any fancy things. You need 2 clear plastic rulers. One goes through the center or the pupillary reflex, and the other passes through the lateral canthus, and you will know the displacement hyperglobus or hypoglobus. So you can actually say there is a proptosis with a displacement downwards of about 3 millimeters. So there's a unilateral proptosis with a downward displacement of so much, or a hypoglobus or a hyperglobus. So it simplifies it, but allows you to measure it in your exams and gives you a little brownie points. Now this is just, again, inspection, palpation, we know the drill. This is something, it's a nice chart which I really like. It's in one of the books, which is chapters, which is going to get published, which really just talks and asks questions, It basically asks if you can see how is it progressing, and these are some of the things that you really like. It comes as a laundry list. And this is something that you can actually tick mark and read. Yes, you can take a picture. Please go ahead if you want. It's going to come in our chapter. It was done by Neerav and me, and just on proptosis. And it's just something to run to, like literally like a ready reckoner. Ki, ye, I have to read this. Okay? So let's come now down to the basics. So we're starting with adults. Unilateral proptosis, yes, it's acute, it's painful. There's eyelid edema, there's a little bit of extraocular muscle restriction. So let's take the first patient. That's his eye. There's proptosis, eyelid edema, chemosis, little bit of congestion, but this is the CT scan. Is there anything? Looks pretty normal, right? Do you think there's something in the CT? It's not a trick question, there's nothing. So when the CT is not matching this, and there's only preseptal edema, it's a preseptal cellulitis with a chemosis, what do you think it could be? Yeah, someone said it, I think. It's just an angineurotic edema or an allergic, kind of edema. It was there was no history of any insect bite, no history of any drug, food, allergy, but literally just resolved without antibiotics. We just gave anti-inflammatories and anti-allergics, and it's resolved. So don't get fooled by pictures like this. Sometimes, just movements were normal. There was a very subtle proptosis. There was this, but the orbit was clear. So, like a proptosis which was so subtle that it was going into an orbital cellulitis. We didn't even have to give steroids. So that's the patient just after anti-inflammatories and anti-allergics. Now, unilateral proptosis, painful, acute, and this is the CT scan. So this is a coronal and axial. So there is here a homogen dense lesion with a slight lining which is lighting up. What do you think this is? Yes, it's a so it's an orbital cellulitis primarily, which has gone into a subperiosteal abscess. So this is acute, unilateral, acute, with restriction of movements, eyelid signs, and that's her after a course of antibiotics. One note is sometimes in these patients, you do need to drain it, but in children, we may not need to drain it if they're under 9 years of age because they usually self-resolve with IV antibiotics. You may need to add steroids 48 to 72 hours later after an antibiotic cover. So second one is, again, similar picture, full ptosis, restriction of movements, but can you see no ecchymosis? So I'll give you a clue. That's a MRI, filled, the sinuses are filled. Patient had COVID. Yeah, my residents have done a PhD on mucormycosis. So as of all of you, so yes, so we have to put this in, mucormycosis. Unfortunately, this was an immunocompromised young adult, so developed mucormycosis, and the management, of course, remains whether you have to give systemic antifungals with or without orbital debridement, and if required, exenteration, but we have also started giving transorbital amphotericin B. Okay, unilateral proptosis, subacute, okay, had a little bit of pain, discomfort, ignored it, and then had a sudden bit of proptosis with diplopia, so, and restriction of movements. What would you think in a young adult like this? There's no like much redness. So I'll just give you the CT scan. Well, inferior rectus, well-defined lesion which are hyperdense. Yes, superb. This is cysticercosis. So more common in, of course, LPS and SR complex, in which you'll actually get a ptosis. So he has a very subtle ptosis, but that's also because of the restriction. The inferior rectus is so tight, it's pulling it down. So you basically give antihelminthics and they resolve. Now let's go from acute to subacute to chronic. So you have painless proptosis with or without restriction of movements, no vision loss. So what kind of proptosis do you think this has, right and left eye? Axial? Axial. So basically intraconal lesions we are looking at. So this is a gentleman who had a nice, well-defined intraconal lesion with calcification. Yeah. Yes. So it was a cavernous hemangioma. But yes, you have other differentials also. But this was a cavernous hemangioma. So the other lady who had a schwannoma. So the only difference in this was there was a little bit of calcification. This is more globular. This is spindle-shaped. I think most of you know this. So intraconal lesion, subacute to chronic. But now unilateral proptosis with an inferior displacement. Okay, and this was the CT scan. I could see it through the superomedial fornix. Anything that's superomedial, superolateral, right here or here, even in an adult, what would you think of? Sorry? Dermoid. There's not much connection with the sinus. So this is a dermoid, very classical, well-defined. So in an adult also you can get, or any of the cysts, epidermoid cysts, dermoid cysts, retention cysts. So we did a transconjunctival incision and got it removed. So transcaruncular actually. Now let's come to the chronic ones. Now all these patients have proptosis unilateral, which is chronic, so in months. So there is some amount of pain, there is some amount of eyelid signs with EOM restriction. So this is actually the differential, which is the commonest differential. There are many more. So coming to this lady, if you notice, she had a little bit of eyelid edema. She has a little fullness on the row eyelid, unilateral proptosis. While this gentleman has upper lid fullness in both the eyes with left-sided proptosis, and this is her scan where there was a lesion in the inferior part. And this is his scan with the orbital lobe of the lacrimal gland. So anything that proptosis, which is chronic, which has some amount of dull, aching, periocular, periorbital pain, you start thinking chronic ailments such as autoimmune diseases, IgG4, thyroid eye diseases. This is basically your differential, where they will come with this classic looking puffy appearance, and they are usually unilateral. So now this is a unilateral ptosis with an eyelid sign. The previous people had ptosis. This one doesn't have ptosis. She has eyelid retraction and lid lag. So yes, thyroid eye disease, and that's post-steroid. Again, similarly here, thyroid eye disease. Now unilateral proptosis, these are a little unusual, but it's important to know. Again, inferiorly displaced lesions as we discussed earlier. And of course, lateral displacement with ethmoid lesions. Now, bilateral ptosis in an adult, which is acute. Now, you're shifting from unilateral to bilateral acute, painful with loss of vision in both these eyes. So, similar pictures. Let's see this CT scan. Look at her muscles. Thyroid eye disease, yes, with dysthyroid optic neuropathy. And look at this one. CCF, so dilated superior ophthalmic vein. So this is bilateral acute. Usually, if you get a bilateral acute, it's pretty straightforward and common. And you will also get those typical corkscrew vessels, and you will actually hear a wonderful bruit if you can, especially if you've seen a CCF. And you don't need to do a CT scan. We usually just catch it with an ultrasonography. Now, bilateral proptosis, acute or subacute to chronic is what we are going. So subacute to chronic, upper lid edema, little redness in the superior fornix, lacrimal glands enlarged. Upper lid edema with bilateral proptosis, lid retraction. No lid retraction here. What do you think this could be and this could be? So we've gone through the other common ones, autoimmune diseases, IgG4, thyroid eye disease. So sometimes some patients still they come to you at this stage. So for thyroid eye disease, where they've progressed already, but they may not have loss of vision. So this is a chronic case of thyroid eye disease, and this is a case of lymphoma. Okay, so bilateral lymphoma actually, so systemic lymphoma with bilateral involvement. Usually it can be asymmetric, most often where patient will present with either a lacrimal gland involvement and you biopsy and you realize it's involving. Now let's take a pause and let's just last 2 minutes. I'm going to go over 1 minute more of my time. Now let's come to children. So children, the most thing is there are a lot of things for chronic, but I'm just going to highlight a few acute ones that we need to know. So acute proptosis, okay, with loss of vision. Both are the same diagnosis. One came without much signs but vision loss, and one came with sudden onset proptosis with redness, lymphangioma. So it will cause a sudden onset bleed. You sometimes need to go in and aspirate it and give a pressure patch, and then plan, or even in the same sitting, plan a sclerosing therapy, which you have sclerosing agents such as bleomycin. So this is in children. Of course, orbital cellulitis is there, which I'm not getting into, but every case is not an orbital cellulitis. You can get a sudden onset in an infant, which could be an undiagnosed lymphangioma. So this is actually a 5-year-old boy who came with a sudden onset proptosis. You can see a scar here has been, he made an incision to do a drainage without imaging, thinking it's a cellulitis, got nothing. So this is a scan. So it's a homogeneous dense mass. So sudden onset proptosis, orbital cellulitis, lymphangioma with bleed, third onset in an infant or a child, what would you think of? Yes, it is a rhabdomyosarcoma. And we could excise it in toto. It was an adnexal plus orbital one. So that's your next one. Finally, this is now going a little more into chronic unilateral proptosis in a 9-month-old girl, increases on crying, worsening, capillary hemangioma. So this is a complex, superficial plus deep, and the management, of course, is now propanol, which works even for orbital. If there is any ptosis which is covering the eyelid and you want to improve the eyelid and not cause amblyopia, then you can do intralesional steroids with propanol. Okay. Unilateral proptosis acute, coming like this with an opacified eye, looking like orbital cellulitis, but this is the CT scan. Retinoblastoma with possible extraocular extension with sterile orbital cellulitis. So this is actually a thusical eye which is shrunken just after chemotherapy. So this is, as we all know, and even Dr. Hunawar keeps harping that in a child who comes within the first 3 years with a proptosis should be done. And finally, this slide is of a unilateral proptosis of a child. He's about 3.5. He came with a sudden onset swelling. Can you see a little bruises here and there? So again, this is leukemia. So the main thing that you need to do is a complete blood count and a peripheral blood smear. The others are dermoids, which you already commonly know, which I'm not getting into. and of course, optic nerve gliomas, okay, which are chronic lesions. So to just summarize, basically just go through the certain questions that we went 1, 2, 3, 4, 5, know your anatomy, and then based on the age, you don't need to know, nobody expects you to know the entire spectrum, but just know the first 2 to 3 top diagnoses. Imaging is something that goes hands in hand with us and we need to know it. And finally, just like to invite all of you to our midterm conference in Aurangabad, which is on 3rd July. It's a one-day conference only on eyelids. Thank you.
Thank you, Dr. Savri. That has been a wonderful talk, and you really have a good collection of pics of patients. Very, very nice. I now invite Dr. Raksha Rao. She's a prolific oculoplasty surgeon from Narayan Netralaya. She would be enlightening us on interpretation of CT scan and MRI, which is a very integral part of for an oculoplasty surgeon to know. So, Dr. Raksha,
Thank you, Dr. URMIL. So that was a wonderful talk by Dr. Savri, and I think she's covered a lot of orbital lesions. So after covering a bunch of orbital lesions that cause proptosis, the next obvious talk would be on interpretation of CT and MRI scan, which you would do in any case of proptosis. Okay. So this is a very basic level of CT and MRI interpretation, which would help you in your exams. So this is going to be an interactive session, so I hope to get a lot of answers from the audience itself. Okay, so CT and MRI scan for orbital imaging, as orbital imaging is done for cases of trauma, for any case of proptosis, for any optic nerve lesion, and for all cases of congenital orbital malformation. So when you order for a CT or MRI scan, you are almost always confused as to what exactly to order. Okay, so this ordering of any of these imaging will depend on basically what your anatomy of interest is. So when you do a clinical examination of proptosis, you will get a basic idea of what the lesion might be, and based on that you order for either CT or MRI. So when the anatomy of interest is the bony wall or paranasal sinuses, then CT is sufficient. When you need to look at optic nerve lesions or globe, you definitely order for an MRI. But of course, B-scan is the most important modality for evaluation of a globe. When you look for the pathology orbital mass lesions, for most lesions, CT with or without contrast is adequate. But MRI is a definite problem-solving technique for any orbital mass lesion where you need a definite characterization, you are uncertain of the tissue of origin, or there is a very atypical appearance on CT scan, and MRI will provide you all the answers that you need. For vascular lesions of the orbit, definitely an MRI. For any disease that is going to be a prolonged course where you need monitoring and multiple follow-ups, then definitely MRI, which holds good for retinoblastoma, any orbital tumors, and thyroid eye disease. Okay, so there are certain areas where you need to get both CT and MRI scan done. This is especially true in a case of orbital pathology, that is congenital orbital pathology. This is a case of craniosynostosis where definitely CT scan is necessary so that you can evaluate how much shallow the orbit is and what the bony orbit pathology is. But however, MRI scan is also necessary for assessment of the optic nerve status and for identifying brain parenchymal abnormalities. A certain place where MRI is absolutely contraindicated is where you're suspecting a metallic intraorbital foreign body. In such cases, the CT orbit is almost always necessary. So when you are presented with a film, how do you identify which is a CT scan and which is an MRI scan? Here, which is the CT and which is the MRI? Can anybody point out? The first image is a CT scan. How do you identify that? Definitely, yeah. So look for all the bones that are highlighted, the nasal bone, the orbital bone, and the cranial bones. And this is not the case in MRI. In MRI, what is highlighted is the brain. Look at all the sulci and the gyri and the optic nerve and the optic nerve sheath. You see the difference between the CT and the MRI? The optic nerve with the sheath is so beautifully evident on the MRI scan. So when you describe a CT scan, always the density is very important. And this density is in relation to the extraocular muscle. So any mass lesion that looks exactly like the extraocular muscle, you define as isodense. Anything that is whiter is hyperdense. Anything that is blacker is hypodense. Okay. Now this density you define with something called as a Hounsfield unit. Okay, now this gentleman, he has come with a definite orbital mass, as you can see, and on the CT scan you see there is a lesion over there. Okay, and you must always ask a radiologist for the Hounsfield unit. Now say the Hounsfield unit, the radiologist has given a value of -90, and this -90 on the Hounsfield unit corresponds to the fat value. So now what is the fat containing lesion that is present on the upper nasal quadrant? Is dermolipoma. Very good. It can be a dermoisis that is completely containing a fat adipose tissue, or it can be a lipoma. Very good. Okay. Now this is another patient who presented with this particular picture. There is reddish lesions in the epicleral area, and on CT scan there is a hyperdense lesion, and the Hounsfield unit is 850. On Hounsfield unit scale, it corresponds to calcium. So what is this pathology and what is this lesion? It may look like AV malformation. Okay, what is this lesion? What is this hyperdense thing that you see here? Something that is calcium. It's a stone, right? It's a phlebolith. Now what can cause a phlebolith is when there is stasis of the blood. What can cause stasis of blood? Is varix. Correct, absolutely right. So this is orbital varix. Okay, so it's a phlebolith. So again, when you describe a CT scan, you must describe the view: axial, coronal and sagittal. Axial is how you see from above or below, coronal is how you see from front, and sagittal is from how you see from the side. And all these are very important views so as to determine the exact location of the lesion. For example, you see this intraocular foreign body, you see on axial section, you can just define that it is okay, it is along the lateral wall. On the coronal section, you see it is okay along the inferior wall, okay, and the sagittal will just confirm the entire thing. And whenever you ask for a CT scan of the orbit, you must always ask for 2 millimeter cuts with sagittal reconstruction, because this gives the exact location of any pathology in the orbit. However, when you're looking for traumatic optic neuropathy, when you're going towards the orbital apex, you must ask for 1 millimeter cuts, because the optic can the canal where the optic nerve passes, it is a very small area, and 1 millimeter sections are very important to decide on what the pathology surrounding the optic nerve there is. So for any CT, for any suspected orbital fracture, you ask for a 3D reconstruction. This is because it can give an overview of the bony pathology, which will simulate intraoperative findings. In addition, you also ask for a bone window. Now, a bone window, in contrast to a soft tissue window, you see that in the bone window, the bone is highlighted. You can even see the Haversian canals in this, and any bony pathology, and even a small fracture, small displacement, any bony pathology is beautifully seen on bone window, unlike in soft tissue window. So imagine this patient who has come with sudden onset of left or proptosis with periocular edema. On CT scan, all you see is a very vague mass. Okay, so what do you do? What do you ask for? You ask for, yeah, definitely MRI is the definite choice, but you can also try with contrast. Okay, contrast will give some characteristic to the lesion. So what you see here is the dilated superior ophthalmic vein. So what is this patient having? Correct. It could be CCF, but she had a different kind of an arteriovenous malformation, but this patient could very well be CCF. There are more investigations necessary, like DSA, to identify the exact vascular pathology. So now, this is a patient presenting with bilateral proptosis. You've already seen with Dr. Savri all these scans. So now, anybody wants to describe this scan to me? How would you describe this? The first scan? what do you see here? There is definite bilateral proptosis. Okay, now there is bilateral proptosis, and what is happening to the muscles? Enlargement, bulging of the muscles with or without tendon involvement? Without tendon involvement. Okay, so this is how you describe. It's a CT orbital, plane, not contrast, and it's an axial section which shows bilateral proptosis, and there is enlargement of extraocular muscle with tendon sparing, and there is no apparent orbital mass. So this is how you're supposed to describe in your exam. Okay, first of all, the view and whether it is plane or contrast, and what exactly it is showing to you. Okay, so now this again in a similar fashion, this is a CT orbital plane in coronal section, and this is at the posterior orbit. As you can see, the section is very much at the posterior level of the orbits, which shows enlargement of the extraocular muscles with no apparent orbital mass. And how would you describe these scans? These are two different patients with their scans. How would you describe this? Okay, let me describe this for you. It is a CT orbit in coronal section, both of this. It shows a mass which is isodense with the extraocular muscles. It is homogeneous mass, and it is at the upper lateral quadrant, and it is not seen separately from the lacrimal gland. Okay, so you agree with me? Okay, now what is the difference between these two scans? What is the additional feature that you see, and what is the difference between these two scans? In the first picture, what about the bones? Not in. Okay, and what about the second one? What is invading the bony structure? In addition, whether the mass is crossing the midline. Is it crossing the midline in the first picture? No. In the second picture? Yes. Okay. So when a lesion is not crossing the midline and there is no bony erosion, it is most likely to be benign, and this is a lacrimal gland pleomorphic adenoma. Okay, and when it is crossing the midline with bony erosion, most likely to be malignant, and this is adenocystic carcinoma. Correct. Now lymphangioma, Dr. Savri has shown you. This is a child presenting with sudden onset proptosis. A CT scan, as she showed, there is a very irregular mass occupying the intraconal and the extraconal space of the orbit. So what does an MRI do? How can you see the difference? There's a definite difference, right? It provides some characterization to the orbital mass, and what is typical in a lymphangioma is the fluid level. So some amount of serous fluid, some amount of proteinaceous fluid, and some amount of blood within a chocolate cyst can cause this typical fluid level. So this is why an MRI is important over CT scan. So how would you describe an MRI? So when you describe CT scan in density, you described MRI in intensity, and similarly in relation to extraocular muscles. Something that is same as extraocular muscles, it is iso-intense, hyper-intense is whiter, and hypo-intense is blacker. So when you describe MRI, there are a lot of sequences that you need not be aware of, but of course it's always a good thing to know all the sequences. But most importantly, you need to know two sequences, T2 weighted images and T1 weighted images. Okay, the difference between T2 and T1, anybody can tell me? Correct. So in T2 weighted images, all the water containing fluid, that is CSF and vitreous, it appears hyper intense. Okay, and in T1 the water containing areas appears hypo intense. Okay, so vitreous is hypo intense and CSF is hypo intense. Now what happens is, as you see in T2 and T1 both, even the fat also contains water, right? So that will also appear hyper intense, right? But there are many orbital lesions which occur within the intraconal space in the fat, okay? And you want to identify it separately. So you need to suppress the fat, correct? So what two scans are most important is T2 fat suppress scans, okay? And T1 fat suppress scans, okay? Now this was totally going out of. Yeah, so in T2 fat suppressor, most of the lesions orbital lesions contain water, right? So in T2, where the water containing lesions appear hyper intense, most of the orbital pathology appears hyper intense on T2, right? But what is hypo-intense is something that you must earmark. So there are only 4 types of lesions that can appear hypo-intense in T1, that is melanin containing lesions, calcium containing lesions, any hemorrhagic lesions, and fungal infections. Fungal infections because these fungi contain a lot of calcium, minerals and all that, so they appear hypointense. So any lesion that is appearing hypointense on T2, something that you must be aware of, okay? And T1, again, like I said, these are T1 fat suppressed image. Any lesion appears hypointense, so whenever there is a hyper-intense lesion on T1, you must be well aware of it, and these are melanin-containing, calcium-containing, protein-containing lesions, and subacute hemorrhage, okay? So in the same fashion, a choroidal melanoma stands distinct in orbital pathology, where on T2 it appears hypo-intense and in T1 it appears hyper-intense. So basically this is the gist, and you must know what a choroidal melanoma looks like, because this is the most important thing for you in your exams, okay? So this is, what is this? Thyroid eye disease. What do you see in thyroid eye disease? Exactly. So whatever you see on CT scan only. So how is MRI better than CT scan in thyroid eye disease is that all you can see on CT scan is there is enlargement of the muscles, there is tendon sparing, but what you can see on MRI is that, see, the muscles, whenever they appear whitish on T2, that means it is containing a little more of water, that means it is inflamed. That means it is an active thyroid eye disease which requires treatment. So once you start treating the patient of thyroid eye disease and it becomes inactive, the hyperintensity of the muscles comes down, and that is why MRI is very useful in monitoring thyroid eye disease. Retinoblastoma, as Dr. Savri has shown on CT scans, that there can be optic nerve involvement and there is orbital involvement. On MRI scan, it appears very beautifully and more clearer and helps in monitoring. Here you see there is optic nerve invasion, and here you see there is a scleral breach, making it an automatic orbital retinoblastoma. Okay, so lastly, MRI scan is also very important in evaluation of all optic nerve lesions. In the case of optic neuritis, you see this left side or left eyeball, there is a proper optic nerve and there is an optic nerve sheath, unlike the right eyeball where you do not differentiate between the optic nerve and optic nerve sheath. Why is this? Because the optic nerve has effaced or expanded into the optic nerve sheath. That is because it is swollen, because there is inflammation, okay? So this is why MRI is, and this you can never see on CT scan. So this is very important in optic neuritis to do an MRI scan. Okay, so an MRI, lot of things, there's a lot of sequences. These are 2 review articles that we have recently published, so you can go through that if you need finer details. So CT scan is pretty much, I think, easy, and whatever I explain now should be sufficient for you. So whenever you're communicating with your radiologist, definitely you must say what you're looking for and what your possible diagnosis is, so that they can translate into a very good report for you. Okay, that is all. Any doubts that you have, if there is any time?
Thank you, Dr.
Yeah.
Raksha. And that was a brilliant talk, and you gave a wonderful overview of all the imaging technologies which is available. So I think our next speaker, Dr. Digvijay, is unable to join us. So Dr. Repka is going to do this talk. Dr. Repka is a senior consultant from RP Center, and she's going to give her first talk on approach to patients with optic disc edema and pallor.
So good morning, everyone. Actually, Dr. Digvijay has unfortunately been tested positive for COVID. So yesterday he requested if I could present his talk. So really unprepared for this talk, but whatever I teach my residents, probably I will try to teach here. So this is on behalf of Dr. Digvijay. This was his presentation. And Dr. Digvijay, as we all know, is the past president of EOC and is the director of Noble Eye Care. So I would like to present instead my talk, which... So basically in this plasty session, we are adding a pinch or a flavor of neuro-ophthalmology. So just because there could be overlapping signs and symptoms, and so even the plasty people should have the idea about the neuro-ophthalmic signs and the various, the manifestations of these diseases. So before we go on to the abnormal disc, first you should understand that what a normal disc looks like. So I think you all must have, as residents, must have seen the normal fundus. You have a well-discrete margins, you have a cup, you have a neuroretinal rim, and of course the vessel surrounding it. So if you know the normal anatomy, then you can come on to the abnormal anatomy. So this is a disc edema, or whether it's a disc pallor. So first starting with the disc edema. So supposedly a case of disc edema comes to you. So you should know that whether it's a case of a true disc edema or a pseudo disc edema. The confusion especially is there when the early cases of papilledema present to you. So they have a very subtle blurring of the disc margins. The vision could be 6/6 in such cases. So how can you differentiate? Because there are a lot of conditions that cause pseudo papilledema. And so the conditions, the most common one is a optic disc drusen. Then there could be pseudopapillitis that you commonly see in cases of hyperopia. So hyperopic discs are small discs. There is a crowding of the nerve fiber layer, and so you see a very blurred disc margin. So we have seen a lot of children, 6/6 vision, diagnosed as papilledema and under treatment with Dymox. So, so it is better to keep such patients on follow-up if you have any doubt in the diagnosis. And on follow-up, look at the fundus picture. If the fundus picture is changing, it means there is some disc edema. But if the fundus picture remains the same, probably it's a pseudodisc edema. And of course, have a look at the vision, color, contrast, and other of the aspects of vision like VP and the visual fields. Then other mimickers of optic disc edema could be abnormal discs like morning glory syndrome, myelinated nerve fibers, or a tilted disc anomaly. So other things that can help you in differentiating pseudo from true papilledema is a fundus fluorescein angiography, where you will see a evident disc leak, and also you can also identify disc drusens on autofluorescence. Then what are the signs of disc edema? There could be mechanical, then there could be vascular signs. So coming to the mechanical signs, these are the basics, you will see the elevation of the disc or the elevation. So in fact, the most initial sign that you will see would be the filling up of the optic cup. So normally a cup which is visible, but if the fluid fills in, the cup tends to fill up. So that is one of the earliest signs of optic disc edema. Then you see the elevation of the disc margin, the blurring of the disc margin. Now what are these lines that you see over here, these folds? Yeah, so these are the patterned line. So in doubtful cases, we also look for these patterns lines, which are retinal or choroidal folds because of the elevation of the disc. And you can also probably sometimes make out the edema of the RNFL. Then vascular signs, what will you see? There is hyperemia of the disc. There could be venous toxicity, congestion. There could be exudates, not only peripapillar, but also macular exudates. There could be nerve fiber layer infarcts and other vascular abnormalities. So remember that do not limit your examination to a direct ophthalmoscopy. Always do a dilated fundus examination because it will give you a better picture of the pathology. We had recently a case referred as a case of optic neuritis. But when we also thought that there is a disc edema, admitted the patient for management. But when we did a dilated fundus examination, we realized it was a case of a choroiditis. So choroiditis that was causing a disc edema. Although the management remains the same, the IVMP was given, however, the prognosis would be different. So then how will the patient present to you? The symptoms would be decrease in vision. Sometimes they can have transient visual obscurations. There could be diplopia, especially if there's a raised intracranial pressure. The patient can present with a sixth nerve palsy, which is a false localizing sign. So there will be a horizontal diplopia and can sometimes also complain of visual field defects. So a history, well, like any disease, history is a very important aspect, and it gives you a clue regarding a lot of pathologies, like whether it's acute onset, subacute, or a chronic onset. Something which is acute or subacute, you would think of a traumatic or a vascular pathology. Something which is, more chronic and progressive, you will think of something which is slowly growing intracranial tumors or some other pathology. So depending on whether the disc edema is unilateral or bilateral, the differentials are following. Unilateral, most important differentials are a papillitis, ischemic optic neuropathy, venous occlusions, intraocular inflammations, or infiltrative or traumatic sometimes. In bilateral, papilledema. Now there are several causes of papilledema that you should rule out. Intracranial space occupying is the most important thing that you should rule out. Then venous sinus thrombosis, malignant hypertension due to raised blood pressures. And if everything comes out to be normal, then probably it's a case of idiopathic intracranial hypertension. Sometimes diabetic papillopathy can also have bilateral blurred disc margins. So a case of bilateral disc edema comes to you, what should be the line of management? So bilateral disc edema, remember, is always an indication for a neuroimaging. What type of neuroimaging? I think a lot has been covered in the previous talks, but contrast enhanced MRI of the brain and orbits. So that's very important. Okay, and orbits, as already stressed upon, it should be fat suppressed because you want to have a look at the optic nerves. So you do the neuroimaging. If you find a space occupying lesion, you have got the cause. If not, then you have to get a lumbar puncture or a CSF analysis done. You don't do it, you refer the patient to a neurologist. The neurologist people will assess for the cells, abnormal proteins, and if everything is okay, also check for CSF manometry. Many a times they miss out on the CSF manometry, the opening CSF pressures, because the proteins and cells could be normal, but if the opening pressures are elevated, this tells you that there is a raised intracranial pressure. So there has to be some cause related to it. Then in that case, if it's a raised intracranial pressure, you have to do a MR venography. So venography will identify that whether there's a venous sinus thrombosis that's causing a raised ICT, and if not, then probably it's a case of idiopathic intracranial hypertension. And accordingly, the management would depend. So there are the clinical staging of papilledema. It could be early, advanced, chronic, atrophic. Early, as the name suggests, mild blurring, which is often confused with pseudopapilledema. Advanced stages, you have established swelling, discrete hyperemia, extensive retinal hemorrhages, exudates. In chronic cases, the exudates tend to increase, and the disc starts getting a little pale. And finally is the atrophic stage, where the atrophy sets in. You will see extensive gliotic changes, and it's a secondary optic atrophy. So this is one case. The patient presents to you with bilateral decrease in vision. You examine the eyes, you see a bilateral disc edema. There are field effects. You go ahead with neuroimaging. So what you see in the neuroimaging here is there is a prominence of the optic nerve sheath. And in fact, there's also a reverse cupping that if you can see here, there's a reverse cupping which is evident that is suggestive of a papilledema. And another sign, can you describe what sign is this? So this, that's actually a partially empty cella. So this is the place where you should have the pituitary. And pituitary should have a similar intensity as the brain. So what you see is just it has been limited to the thin strip of tissue, and it's mainly filled with CSF. So it's a partially empty cella sign. It may be seen in normal individuals, but in the presence of papilledema, it's suggestive of a IIH. Okay? So one of the soft signs for IIH. Then, of course, you do a MR venography. You rule out a venous sinus thrombosis. You might, say that here on the left side, it appears to be a little thinner, but it's actually a hypoplastic venous sinuses, which is again often confused with venous sinus thrombosis, and patients are overtreated. So hypoplastic venous sinuses is a normal thing, which may be seen, but it doesn't cause a raised ICT. So the MRV is essentially normal in this case, so it's a case of a idiopathic intracranial hypertension. So the typical patient profile is a young obese women. The causes are obesity, then certain drugs can cause it like vitamin A, growth hormones, carbidopa, etc. The patient presents to you two most important complaints: headache, vision loss, okay? CSF opening pressures more than 25 centimeters is considered to be significant, and there's also a criteria for IIH that you should go through. How do you manage it? Medical management, you use carbonic anhydrase inhibitors and other, diuretics to lower the ICP. If it doesn't work, then we do optic nerve sheath fenestrations, and if not, then you go ahead with the VP shunt surgeries. Then coming to another case, but here what you see that this patient had a bilateral disc edema, but what is unique is that you see a lot of cotton wool spots and extensive hard exudates. So this goes more in favor of a raised blood pressure. So because there is presence of hypertensive retinopathy as well. So it's important when a case of papilledema comes to you, especially in young patient, also get a blood pressure checked. Then diabetic papillopathy, although they will present with bilateral disc edema, but usually it's a benign condition, does not affect the vision, it is reversible, and younger diabetics are more susceptible to it. Optic neuritis, well, in optic neuritis, it could be typical or atypical. Now the typical one, as you see, the patient has this complaint, a young female patient presents to you the initial deterioration for initial 1 to 2 weeks, and thereafter the recovery begins spontaneously. So that's a typical course, okay? So in a typical disease, so whether it's an optic neuritis, then whatever doesn't fit into the typical picture becomes a atypical optic neuritis, like extremes of ages, then bilateral optic nerve involvement. Then if there is a poor vision recovery, a very severe vision loss, all this becomes atypical optic neuritis. Whether typical or atypical, you need to get a contrast enhanced MRI of the brain and orbits, okay? In fact, in atypical cases, you can also get a contrast enhanced MRI of the spine, because you have to rule out the transverse myelitis, like in cases of NMO spectrum diseases or MOG positive cases or MOG cases, okay? So, how will they present to you? They will present with a decrease in vision, mild tenderness on eye movements, central centrocecal scotomas, and this is basically a typical picture that you will see in a multiple sclerosis. So typical demyelinating lesions which are perpendicular to the periventricular area, these are called the T2, Dawson's fingers. And also what you see, as Dr. Akshay has just discussed, there is a enhancement, post-contrast enhancement. So that's why contrast becomes very important, because when you see this enhancement, you know that it is inflammatory. So one case, we see a 56-year-old male patient, diabetic, hypertensive, presents to you with a sudden decrease in vision that was noted on waking up in the left eye. So you check this fundus and the diagnosis is glaring at you. What do you see over here in the left eye? It's a pale disc, but what type of atrophy do you think it is? Secondary optic atrophy, yes. You get the visual fields, it's a kind of a inferior altitudinal field defect. So this is a case of a NAION, okay? Then, so NAION is a non-arteritic ischemic optic neuropathy, a very common condition that you will see in elderly patients. So unilateral disc edema in elderly patient most likely is a NAION. Then important differential for NAION is a arteritic ischemic optic neuropathy. So arteritic is a medical emergency, it's a life-threatening condition. The management is very different for the two. For NAION, you essentially don't do anything and might give a trial of steroids if the patient is not diabetic. But in arteritic, it's a medical emergency, you have to treat the patient immediately with IVMP, methylprednisolone. So how to differentiate? You get the, usually the vision loss is very, very severe. In cases of arteritic, patient might have other systemic symptoms like, the jaw claudication, the tenderness in the temporal side of the head. And so you have to get ESR CRP done, because if the ESR CRP is markedly elevated, that goes more in favor of arteritic. Usually the age group for arteritic is an elderly patient, 70s and above. And that's how you differentiate. But if it's a case of NAION, which you more commonly see, you have to rule out the systemic risk factors like diabetes, hypertension, hyperlipidemia, hyperhomocystinemia. Get these blood investigations done. So now coming to pallor. Well, pallor, it could be primary, secondary, consecutive. Primary, well, it is related to a compression which is happening behind the optic nerve head. So in fact, the new terminologies that we are using is optic atrophy associated with disc edema and optic atrophy not associated with disc edema. So optic atrophy which is associated with disc edema is secondary, and we have just discussed the causes. Optic atrophy without a disc edema, well, includes your hereditary, nutritional, toxic, and consecutive is the one that occurs secondary to retinal or choroidal diseases. So the one such example of glioma, I think this has been covered, a case of glioma causing a unilateral optic neuropathies. I'll just discuss the cases. A patient presents to you with a bilateral decrease in vision. There was no history of alcohol or drug use that might have led to a decrease in vision. Pupils were affected, vision was affected. So what you see is a markedly stark pallor, okay? Although there's cupping, you might get confused with glaucoma, but what you see is a marked cupping and, marked pallor, and there is a bitemporal hemianopia, so you immediately get a neuroimaging done. So this kind of a field effect respecting the vertical meridian has to be neurological. So that's a suprasellar mass, most likely a macroadenoma, pituitary macroadenoma. So another case, a young patient who started with a decrease in vision 2 months back in one eye followed by other eye with mild fluctuation in vision. So young patient, bilateral decrease in vision, gradual onset, slowly progressive. So you see the disc, these are severely pale. So again, your first step would be visual fields. You get the visual fields done, you see central scotomas. So central scotomas usually go in favor of metabolic, nutritional, toxic, etc. So, but you should always get a contrast-enhanced MRI of the brain and orbits to rule out, in case any underlying lesion is there, it's reported to be normal. So considering that most likely it's hereditary, as the patient did not have any history of drug intake, We got a genetic analysis done for the patient. It came out to be positive for LHON, okay? So LHON you can test for 3 primary mutations, but apart from that, you can have other mutations also. Okay, so just quickly, there's last case, a patient of tuberculoma on ATT for past 2 months, and post-ATT has started complaining of decrease in vision. So what you see is a marked temporal pallor, mild temporal pallor, and on again you see the visual fields, you see the centrocecal scotomas. So this was a case of a toxic optic neuropathy. Well, again, here I would like to say that if a case of TBM comes to you, tuberculous meningitis, do get a contrast-enhanced MRI of the brain and orbits, because sometimes you can have a paradoxical reaction to drugs, where post-ATT, suddenly the tuberculomas appear or enlarge in size, and they cause a decrease in vision, okay? So that's your toxic. And just in brief, that neuro-ophthalm case comes to you. This is the basic examination. So do check for color contrast visual fields. You might not have a color or a contrast chart available with you, but you can at least use any bright object and ask the patient to see monocularly. A very simple way. Assess the pupils, assess the fundus, look for the fields. Neuroimaging, very, very important. Genetic analysis, where you're suspecting hereditary optic neuropathies. You might go for CSF analysis, especially if you're suspecting infections like meningitis. And of course, you should be able to differentiate between a glaucomatous and a non-glaucomatous disc, and that's a completely separate topic altogether, which we cannot cover today. Thank you.
Thank you so much, Dr. Rebecca, for covering this challenging topic so well. I know the residents find it a bit difficult also, but thank you so much. And while you take a break before you give your next talk, I'll go further into neuro-ophthalm, and I'll invite the head of department of neuro-ophthalmology from Shankara Netralaya, Chennai, Dr. S. Ambika. She's going to speak on localizing the lesions made simple.
College. There, in the preview room. You have not taken.
Stay back if they are there still, so that we can have questions in the end if residents want, if they're not very hungry yet. and we can have a group photo also. I think the speakers are giving their talk and moving away, but if in case anybody is there or outside, please request them to stay back. Yes, Dr. Rebecca.
Thank you, ma'am. I think a little more tickling of the brain, because we have another topic in neuro-ophthalmology, which is your typical visual field defects. Now, it's important not only for your exams, but also for your PG or fellowship exams, because these type of field defects could be asked, okay? So first, understand why to do a visual field examination. So first, because it helps you in the diagnosis of the neuro-ophthalmic conditions. Then it gives you a probable idea about the site of the lesion. And in certain conditions, it acts as a screening tool, like in toxic optic neuropathy. A patient on ATT comes to you, you should get a baseline color, contrast, vision, and visual fields, so that when the toxic optic neuropathy starts, you can catch it on time. Then on follow-up, you can monitor the disease progression and accordingly guide the treatment, like cases of IIH and pituitary adenomas. And lastly, when patients with a permanent vision loss, you can evaluate the disability scores. So many a times, we give handicap certificates based on the visual field defect, and also it guides the patient rehabilitation. So how can you assess it? Just in brief, you can use either automated static perimetry like Humphreys, or you can use a Goldman kinetic perimetry, especially if you want to have an idea of the peripheral visual fields. Now, if nothing is available, you're sitting in a peripheral center, use a confrontation test. Confrontation is a simple bedside test that will give you a gross idea about the large field defects. And sometimes we have also used Amsler's grid to chart central or centrocecal scotomas. So normal limits of visual field, superiorly and inferiorly, it's almost 60 to 70 degrees. Nasally, the field is a little limited as compared to temporal. Why? Because the nasal bridge comes in. Now, a few terminologies that you should know before we discuss this topic. One is hemianopia. That's the involvement of one half of the vertical visual field. Quadrantenopia, involvement of 1/4 of visual field. Homonymous term basically means the involvement of the same side of the vertical midline. To brush up your basics of the visual pathway anatomy, the receptors are the neural epithelium of the rods and cones. First order neuron are bipolar cells, second order neuron are the ganglionic cells. Then the axons of the ganglionic cells make the optic nerve. Then from the optic nerve, you have the chiasma. So what is interesting about chiasma? The lateral fibers go into the same or the ipsilateral side. But the nasal fibers, they decussate over to the other side. And that constitutes your optic nerve, optic tract. From the optic tract, the fibers end into the lateral geniculate body. And from the LGB, the third order neuron arises, go into the optic radiations, and end in the occipital cortex. Now, this is a very important slide because it covers the major share of this topic, if read properly. So it tells you that what are the various types of defects that you will see based on the site of the visual pathway involvement, and I'll be discussing them one by one. So first, what's the relationship between the visual fields and the retina? So remember that the image that is formed on the retina is inverted and reverse. So inverted means the superior falls below and the inferior falls above, okay? And similarly, reverse means that your left side of the visual field is projected on the right half of retina, and your right half of the visual field is projected on the left half of the retina. But you know, visual fields are not mutually exclusive as you see over here. Rather, they are overlapping. So you have a large overlapping central binocular visual field, and there is a peripheral rim of monocular visual fields. Now, what type of field effect will you get? Well, in retina, it depends on which layer is affected. If your outer retinal layers are affected, there's no particular pattern to it. But if inner retinal layer, that is nerve fiber layer, is affected, then it is there that the patterns begin. So why? Because nerve fiber layer has this peculiar arrangement, which you all must have read in anatomy. You have papillomacular bundle directly going from fovea to the optic nerve head. Superior and inferiorly arching are the arcuate fibers, and then you have the radiating, superior and inferior radiating fibers are present nasally. So because of this arrangement of nerve fiber layer and the way they enter the optic nerve, you have this kind of the fiber arrangement in the optic nerve head, where you see the macula present temporally and rest of the fibers arranged nasally. Then also peculiar is that the peripheral fibers arising from the peripheral retina, they remain peripheral in the optic nerve, while the macular fibers, they remain central. So as you move from the nerve head to the optic nerve, the macular fibers, they become more central. Now, coming to the field effects. Now, what type of field effects will you get if RNFL or optic nerve head is involved? Well, depends on the type of nerve fiber bundle which is affected. But what is characteristic is that these defects will originate from the blind spot and not from the central fixation. And also, they will respect the horizontal midline, okay? So if there is an involvement of the papillomacular bundle, you might see a central scotoma, that is here, a centrocecal scotoma, or a paracentral scotoma. If there is an involvement of the arcuate fibers, you might see an arcuate scotoma and altitudinal defects. And if there is nasal fibers which are affected, you will see temporal wedge-shaped defects. So this is one example. Can you tell me what type of scotoma is this? So yes, it's a centrocecal scotoma, because it's, you know, yes, it's connecting the fixation with the blind spots. So that becomes a centrocecal scotoma. So this is a typical differential that you will, you know, the typical differentials would be optic neuritis, toxic, nutritional, hereditary optic neuropathies. In my previous presentation, I showed you that how a case of LHN presented with central scotomas, okay? So now another case, what you see in this right eye, so there is a disc edema. But what is typical is it's a pale disc edema, not a hyperemic disc edema. So hyperemic disc edema goes in favor of papillitis. Pale disc edema goes in favor of ischemic optic neuropathy. And when you get the visual fields done, you see an inferior altitudinal defect. So this is a case of NAION. So sometimes you might get confused between inferior arcuate defect versus a pie on the floor, which is a quadrantenopia, okay? So this picture, what do you think it is? It is an arcuate or a pie on the floor? So had it been a case of an optic nerve lesion, then it would have been connected to the blind spot, and it would respect the horizontal midline. But what you see over here is that it's respecting the vertical midline, and it is connected to the central fixation, okay, arising from the central fixation. So this is more likely a retrochiasmatic lesion that's causing a pie on the floor. So arcuate field defects you not only get in glaucoma, but you might get in other conditions like choroiditis, CRAO, BRAOs, papillodemas, especially chronic papillodemas. So this is differentiating features between the lesions which are present anterior to chiasma versus the lesions at or posterior to chiasma. So anterior to chiasma, basically it's an optic nerve involvement. So it will be usually unilateral. Unless it's a bilateral pathology, there could be RAPD. You can see disc changes like edema or exudates, and the field defect is unilateral. But if it's posterior or at the chiasma, the bilateral pathology, the bilateral field defects begin. The vision loss becomes symmetric and bilateral. You do not see an RAPD, you might see a vernix pupil. And the disc might just show a pallor, but you might not see any other pathology in the disc. In optic chiasma, what is important is that apart from the nasal decussation, you should know about the von Willebrand's knee. So what is that Willebrand's knee? Well, when the lower nasal fibers are decussating in the chiasma, it actually takes a little turn into the posterior part of the contralateral optic nerve before it joins the optic tract. So these lower nasal fibers actually represents the superotemporal field, and its clinical significance I'll discuss later, okay? So, and you should be aware of what are the various relations of the chiasma around it, because these relations can actually tell you that what type of defect and where the lesion could actually be. So if it's a case of sellar or suprasellar tumor, it will cause a central chiasmal compression, and since it is the nasal fibers, it is affecting the crossing nasal fibers. So nasal fibers means your temporal visual field. So what type of defect you will get? Bitemporal hemianopias. So an immediate indication for neuroimaging, and the DDs would be pituitary adenomas, craniopharyngiomas, or meningiomas. Rarely you can get a lateral compression of the chiasma instead of central, and here you might see binasal hemianopias, but it's very rare. Then what's the significance of von Willebrand's knee? So it's actually, it indicates that if there's a lesion at the junction of the optic nerve and the chiasma, so what happens is that it not only involves the affected nerve, but you also get some scotoma in the contralateral eye. So lower nasal fibers are forming the Willebrand's knee in this optic nerve. So you get a superotemporal defect. So this is called a junctional scotoma. So this indicates the lesion is at the junction of optic nerve and chiasma, okay? So that is about the Willebrand's knee, so you might get a question related to it. So in optic tract onwards, the temporal fibers of ipsilateral eye and nasal fibers of contralateral eye both combine together and represent one half of the binocular visual field. So from here, the visual field defects, they become homonymous. So, but remember that as you go more towards the visual cortex, they become congruous. So what is congruity? Congruity means the exactness of the visual field defect in the two eyes in terms of size, shape, location. So the more you are towards the cortex, the more congruous the defects are. So you see in case of optic tract lesion, you get incongruous defects. You might also get a little atrophy and vernix hemianopic pupil. So what is a vernix hemianopic pupil? Half of the retina, intact retina, you're projecting the light, you get the pupillary response. On the affected half, if you're projecting the light, you don't get a pupillary response. So LGB, it is typical for sectoral homonymous hemianopias because it has this typical blood supply because of that. Then optic radiations, the third order neurons arising from LGB, they move into the optic radiations. Now here there's a differentiation. There are two fibers, superior fibers and inferior fibers are separated. So your inferior fibers coming from inferior retina, but they represent the superior visual field. So they pass into the temporal lobe. They form the Mayer's loop. So if this is affected, you get a pie in the sky. So temporal lobe, pie in the sky. And while the superior fibers representing the inferior visual field, they pass in the parietal lobe. So parietal lobe lesion will cause a pie in the floor. So this is one example of a pie in the sky. And when we did a MRI, what we found was a MCA infarct, and that was affecting the temporal lobe. So other neurological signs that may be seen in temporal lobe lesions could be seizures, aphasia, or hallucinations. Then in parietal lobe, asymmetric optokinetic nystagmus is one feature. So just look for other associated neurological and systemic signs, okay? So finally comes the occipital cortex. Well, as you see, that macula has the highest representation. Almost 70 to 80% of the tip of the occipital lobe is actually representing the central 30 degrees of the visual field. And rest of it is the superior fibers are projected on superior to calcarine fissure and inferior fibers inferior to calcarine fissure. So here you get congruous contralateral homonymous hemianopia. Okay, very typical. And you see like a right homonymous hemianopia, and you see a left-sided occipital lobe lesion. Sometimes, just my last slide, sometimes you might see a small macula sparing defect, okay, homonymous hemianopia. Now, why do you get this macula sparing defect? You need to understand the blood supply, okay? So blood supply of the occipital or the tip of the occipital lobe, it is receiving the blood supply from both PCA as well as the MCA, so posterior and middle cerebral artery. So in case of a PCA infarct, the branches from MCA still continue to supply the occipital lobe tip. So if this anastomosis is present in a patient, then the tip is spared and you get this macula sparing.
I think we
lesion.
can wind up,
Yes,
Dr.
ma'am.
Repka.
So that's it. And just last slide where you see that sometimes there could be coexist, the pathologies may coexist. So we had this case of a glaucoma on follow-up for quite some time. You see these typical arcuate defects, but what he recently developed was this kind of a hemianopia. So this warranted immediate neuroimaging, and the patient, we did find something in the brain. So remember that even with a known pathology, if the patient is on follow-up, a regular follow-up visual field scannings are important. Thank you.
Thank you, Dr. Rebecca. Again, covered the very mind-boggling topic, I would say, very well. I'm sure the residents, when I was a resident, I always used to find this very tough. Anyways, I again invite Dr. S. Ambika. She's HOD in Shankara Nethralaya Neuro-Ophthalmology Department. She'll be talking on localizing the lesions made symbol. This is our last talk before we take a lunch break.
Thank you, Chairperson. And I think the conduction delay of my talk is also for good, because you have got already an overview of the fields. Now let me make only case-based specific discussions, because I don't know, I prepared for a 15 minutes talk and I have ended up for a 5 minutes talk now. So let me put it, localizing of lesions, first of all, whatever the symptoms you come across, that's going to decide where and what you're going to look. So if a patient, most common thing what you see as a neuro-ophthalmologist is a vision loss, and they're followed by a diplopia, and I think field is already covered. Whatever be the complaint, you have to go with a detailed history taking, because by the time you finish doing the history taking, you will have a picture of what type of lesion you're going to deal with. And this is the entire visual pathway, and I have put it into 4 separate groups where we can discuss, right from the optic nerve to the chiasm, the retrochiasm, and the cortical lesions. So any optic nerve disorder is going to have all these sort of dysfunction: a vision loss, color, pupillary dysfunction, a contrast, a visual field. An optic neuropathy can range from a normal appearing optic nerve head to disc edema to a disc pallor. So better we will make it as interactive as possible. This is a 30-year-old female who came with the complaints of sudden drop in vision in the left eye. So she has CF vision, and that's the disc what you see, and the right is apparently normal. So what's the next investigation you would ask for? One investigation which is going to give you a clue. I said there's an optic nerve dysfunction. You have to ask from your clinic a visual field first before deciding an imaging. So always go in a stepwise fashion, okay? But if you could ask me, the patient has a CF vision, and how could you manage to get this visual field? That's the question you should ask me. This is the field which was done by the patient couple of days before, when the patient had a 660 vision. And also be aware of the different visual field chartings. Okay, the previous speaker showed a lot of Goldman fields, and that's also very good, but we do have a lot of Humphrey fields nowadays, and it all depends on the center where you go for the exams. So this is an advanced field loss of the left eye with the right eye normal. And what type of imaging it is? What is the first one? I've revealed. So what is the first one, what you see? That's a coronal. Do you have a pointer? Should do here. Is it okay? Yeah. So the first image is a coronal MRI image where you see enhancement of the left optic nerve. Okay, this is the left optic nerve which is getting enhanced, and this is the axial MRI. And you see the diffuse thickening of the left optic nerve, and it is also bright in signal, okay? That's a patient of a MOG positive disease. So first of all, the previous speaker has highlighted what is typical, what is atypical. Now add to the ooze, we have a lot of seromarkers in the atypical groups. So this is a patient with an atypical optic neuritis where she is MOG positive. Why should we do all these antibodies? The management pattern differs, okay? So that's a MOG positive disease, and here the lesion is just along the optic nerve. So now come to this patient who is a 37-year-old female, and it's a sudden decrease in vision, which is painful, and she also complained of fever 3 weeks back and a headache, and she has a right eye 618 vision and left eye is apparently normal by all means. And one brilliant history she gave is there's a history of tuberculosis in the brother. And remember, again and again, we are living in India. That's where we have TB swimming around us. So be careful before making a diagnosis and putting the patient on a long-term steroids. Be very careful if the patient is going to have a latent TB. So this is the disc appearance, what you see in the right eye. There's a florid disc edema and left apparent. This is the right eye disc edema. And what type of field effect you are seeing here? That's an inferior altitudinal field loss, and this is a OCT which showed quite a huge disc, and that's a bulky granuloma which is sitting behind the nerve. So when you see a disc with such an appearance where we suspect a granuloma, see, this is a condition where you have to be careful, where you have to see the nerve. This is an axial flare and a fat suppressed technique where you see the optic nerve sheath is enhanced. Okay, here the sheath is involved. The location is in the sheath rather than the nerve itself. So this is entire nerve is thickened with a sheath enhancement. And what you're seeing here is the optic perineuritis. So this is optic perineuritis, and the earlier one was an optic neuritis. So the investigations revealed that she is also positive for TB, and so we put her on ATT along with steroids. So within a month, you see the vision has started improving, and see this is the same visual field what you saw as an inferior altitudinal loss. So this is a third patient where she is a 47-year-old female who came with the complaints of painful diplopia which improved with steroids, which was treated elsewhere. In fact, she was referred to us as a thyroid eye disease. So she came with a sudden drop in vision in both the eyes, with the left eye more than the right eye, and left eye had a 612 vision, whereas the right was 6:9. So what do you see? What's your first thing which comes up? She has a history of pain. Her all extraocular motilities are restricted. So, okay, very nice, very nice. That's a nice thought process pre-lunch. So thyroid profile is normal, okay? And no trauma, no bruit, pain. So still, that's the disc which is appearing like that. So what is the next investigation you would ask following the disc? Exactly. So that's a visual field. So you see a visual field which is not that badly involved, but still there is some central defects in both the eyes, okay? That's the MRI. Now I think you will definitely enjoy this MRI. What do you see here? Thank you, Rebecca, for coming before me. What is this? You see the extraocular muscles are thickened, and you see there's one more thing. Is it extending to the tendon? It's also involving the tendon. So when you have a EOM thickening which is spreading to the tendon also, then that's something which is not a thyroid, okay? And now the level of lesion is here because there's a compression at the apex. It's in fact bilateral orbital apical compression because of the gross thickening of the extraocular muscles. So this is the coronal cuts which has measured all the extraocular muscles, and our working diagnosis with a history of pain that is responded with a steroid is this group of list of differentials. And most of you have said right, yes, we started her on steroids, but since she had a recurrent event, we went ahead, did a biopsy of the extraocular muscle which showed that it is an inflammatory myositis which showed a classical granuloma on a histopathology. So that's a sarcoid-related myositis which caused an orbital apex compression. Here, the location of the vision loss is at the orbital apex. So you have to decode, this is the treatment, post-treatment follow-up of the same patient. So moving on to the chiasm, and apart from all the optic nerve dysfunctions, you be careful in eliciting the, yeah, we have 5 more minutes, he has reminded us. So the signs of the chiasm syndrome, we will go boss, don't worry. So apart from the optic neuropathy, we can have a papilledema. If the cellular lesion is going to spread up, if it's going to go supracellular, it's going to compress the third ventricle, and you're going to end up seeing a papilledema, which is not that very common in a chiasmal condition. You can see if it goes to the paracellular compartments, we will start seeing cranial nerve palsies. And seesaw nystagmus, not very many patients I have seen with a cellular mass lesion with a seesaw. So let me make this, always remember, don't go with only what you see. Okay, this is a guy who was referred to us as a road traffic accident following vision loss as a traumatic optic neuropathy. Looking at his face, what is the thing you grossly see in him? Do you see any facial asymmetry? Yes. So there's a drop in the vision in the left eye, but it's a duration of 4 years, he claims to be. He has 3/60. He had a CT orbit which had multiple fractures, and there's gross enough also to say that yes, it's a periorbital fracture that's causing it. And what is one thing which is not going with his optic disc, right and left? What is one thing which is not matching in this? Is this disc a 4-year-old optic neuropathy? No. So his only condition is probably he mistook that. And what is another thing? He has also got a CT orbit with multiple fractures. Okay, now one more clue. What is the next investigation? Fields. Now you come to this fields. So what is the type of fields you see? This is a size 5 program of a Humphrey visual field. What is the type of field you see? Where is the blind spot? Could you differentiate? That's the left eye fields, and the blind spot is here. This is the right eye fields, and the blind spot is here. So what you see here, that's a superotemporal defect with a dense field loss. There, the level of lesion is not the CT orbit, okay? So you should have, unfortunately, if he got imaged slightly up, he would have picked the lesion. So that's a cellular lesion. What you see, that's a huge hyperintense chiasmal lesion, and the same patient post-surgical intervention, this is the visual fields which showed a good recovery. So don't settle down with a CT orbit, although it showed a orbital fractures and an NOF, that was not the reason for his vision loss, and the lesion was somewhere else located. Do we have time for another case? Yes, ma'am. So there's a 41-year-old female who was referred again as a thyroid eye disease with some lit signs, but the only thing is she also had a right side drop in vision. So there was a right side drop in vision, and this is her extraocular motility. What do you see here? What do you see here? There's an adduction restriction, and what is here? There's a lag on down gaze. Here, there is an elevation restriction. And can you see the palpebral fissure when she's trying to adduct? Go through this. So there's some mild widening also when she does a adduction. So this is not a typical thyroid eye disease, okay? So there is a vision drop. There are signs of a right third nerve compression with an aberrant signs of regeneration with a vision loss, and this is her visual field. What type of field loss is this? Which area is this? The blind spot is there. So that's the area of, is it nasal or temporal? That's the blind spot. Blindly say if you see a blind spot, that's the temporal quadrant. Okay? And do you see a blind spot here? So that's the temporal field. So again, a bitemporal field loss, which is causing the vision. So that was a huge paracellular component which started, that's what I said, a cellular mass, when it falls into the paracellular, it's going to cause a cranial neuropathy also in addition to the vision loss. There the lesion is located. So the same patient post-surgical treatment, there's a recovery of the visual field. So I think Dr. Repka has covered this. One thing you remember, if you see a homonymous hemianopia, which is incongruous, which means it's slightly anterior. If it's higher in the cortical zone, it's going to be highly congruous and mirroring effects. And this is what type of field effect is this? Beautiful. That's a right pie in the floor. And what you see is a huge lesion which is sitting in the left parietal area. And this is last case which came with the complaints of sudden drop in vision and his 6/9 N6 with a normal appearing fundus. One thing, what type of field loss you are seeing? Which side? Which side field loss, right or left? What type of visual field defects you are seeing? Go on, shoot. That's a homonymous hemianopia, right or left? So where do you expect the lesion to be? That's it. So that's a huge right PCA, MCA area of infarct, but the patient is still having 6/9 N6, but he's grossly incapacitated because of this visual field defect. Okay, so this is one last slide which I'm going to close it with. You're getting a 65-year-old male who is brought by the son with a complaint of sudden drop in vision. He's got a gross, dense cataract and his pupils are briskly reacting to light. Remember, pupillary dysfunction will not be there in retrochiasmal higher cortical area lesions. So he's got a perception of light with dense cataract and fundus is normal and all the neuroophthalmic evaluations are normal. So what is the next thing you would ask for? Cataract is there, you're going to operate him. So what is the next thing? But your cataract alone is not the reason for his drop in vision, because when there is a sudden drop and a patient, he's saying, the son is saying he was apparently fine till yesterday, but he has come suddenly last 2-3 days with he's groping in the room. So what do you think? So here is the role of MRI brain and orbit. Do not touch this guy for a cataract surgery without ruling out this condition. What he had was a left side hold infarct in the PCA zone. That's an occipital infarct. He already had a poor vision in the left eye and he was bonking on with his right eye, but right eye also developed a right PCA infarct. So that is the reason why he developed a severe cortical visual impairment. So when you touch such cataracts, you have to be very careful because the visual prognosis is extremely guarded. And I think I end with this, and I'm not going to go into the diplopia cases. So to finally, so to conclude, always in neuroophthalmic history taking is the key. Okay, so when you come down with the history taking, you will be aware what type of evaluation you're going to do. And always ask the radiologist to do the correct imaging and give them a clinical clue, because if you're not going to give them a clue, they're not going to come up with the diagnosis. So watch for it, be careful when you ask for the imaging, and do not ask for an a CT for an optic neuritis. That's obsolete. Better don't treat that. Better don't get an imaging if you're not having an MRI. So thank you so much for this opportunity, and I wind up with this.
Thank you, ma'am. Thank you. It has been a wonderful presentation, very interesting cases. I'm sure everybody has been enjoying it. So with this, we come to the end of this session that has had oculoplasty and neuroopthal together. And I can see that everybody is too hungry to stay back. In any case, everybody is welcome. If anybody has any queries, we are still there, or else we disperse for lunch.
One thing I would like to make a point. It is not a must that NAION should happen only in elderly age group. Nowadays, we see a lot of patients in less than 40 years having a non-arthritic anterior ischemic optic neuropathy, particularly when we have conditions like atypical optic neuritis, which is going to slightly straddle 40 plus, painless, with a poor recovery. Be careful before making a diagnosis of NAION, because a lot of Morg spectrum diseases are mistaken for NAION and not afford a treatment. That's one point which you have to remember, because Morg spectrum disease has a brilliant recovery post steroids, whereas your NAION doesn't respond to steroid. So be careful before differentiating that. Thank you so much.
Thank you for the tip, ma'am. Dr. Rebecca, can we have a group photo? Any other speakers are still there? I think everybody has left. Okay, let's have the three of us. So all of you can disperse for lunch, And you have the next session at 2:30, I think. All the best. Hope you all enjoyed the session.